It gives me great pleasure to introduce, or rather, let Dr. Cox have the last word of this meeting. I hadn't realized until yesterday when I was looking up Dr. Cox that he was actually offered a professional contract to be a baseball player with the LA Dodgers. So obviously,
sometimes I think I should have done that.
Their loss is our gains.
Thank you very much. Well, this has been a really great day. I've really enjoyed all the talks and the controversy, and I think being the old gray head around here and listening to all these young guys talk is very encouraging, because I think that the main thing is that a lot of very bright, very talented young surgeons, very learned young surgeons, or younger than I at least, are approaching this in their own way. And I think everybody has a little disagreement about, how it should be done and so on. But I think that that's how progress is made. So I'll just make some quick comments about what I think may be in store for the future. But it was really good to have these last two talks, because I think they represent really the choices. I mean, you can have a choice of doing a hybrid procedure in one way or another, or a choice in doing an on-pump, truly minimally invasive maze procedure. And clearly, I think the main reason, as Mark said earlier, the main reason for trying to do the hybrid procedures is that it's apparently the only way we're going to get involved. We've been trying to do minimally invasive, or doing minimally invasive maze surgery now for almost 20 years. And a lot of people have accumulated huge results, some of which were shown today, but huge experience, and it works fine. I mean, we always had exactly the same results with the minimally invasive cryo procedure, just like you did it, that we had with the open cut and sew. But as either you or Mark, one or the other, mentioned, the devil is the pump. And that's what the cardiologists who are the gatekeepers can't seem to get over. And I've pounded my head against the wall for the last 15 years, so maybe you guys can pound your head against the wall the next 15. The current status, and these are U.S. figures, so whatever I show here, you can pretty much multiply by 1.5 for Western Europe, Western Eastern Europe. But today, about 2% of all the people who have atrial fibrillation undergo catheter ablation for atrial fib. That's after 20 years or so and a couple of $3 billion pumped into the system. There are about, the rest of the people are treated with drugs, 95% of them. About 3% of patients have atrial fib associated with surgery, or surgery for other problems, and are in the concomitant group. And of that 3%, we have a very small penetration, 20 to 30% penetration. So despite the fact that all this money's been spent and all this effort's been spent and all this brain power has been spent over the last 25 years, and the results are good, they're better than medicine, and so on and so forth, this is still where we stand right now. Only about 5% of the patients are subjected to any kind of therapy other than drugs. Let's talk about concomitant AFib for a moment. I think the problem in concomitant AFib is very apparent, at least in the States. This comes from a 2009 study. Jim Gammey's study, I think, was a little more recent than that, but and showed the results are a little bit better, especially for mitral. But with the most in-depth look at this shows that we treat about 20% of the patients who come to the operating rooms with atrial fibrillation in the United States, and we do not treat the other 80%. They're simply ignored. Not treated, 80%. That's the big problem in concomitant AF, in my opinion. Now, there was a questionnaire passed around at the AATS a few years ago. The main reason that these patients aren't treated, according to the surgeons who were attending the AATS, is they're worried about the safety. They don't want to add risk to the procedure. Well, Nevad wrote this paper shortly after that survey was taken, and noted that this is in patients with aortic valve disease and coronary artery disease. And he said the addition of a MACE procedure to those two problems, the primary procedures, did not convey an increase in morbidity or perioperative risk. And in matter of fact, they thought that their patients probably actually did better. That was for aortic valve and coronary. Ralph Damiano did a similar study for mitral valve surgery. This is where most of it occurs, of course. In absolute numbers, most of it occurs in coronary disease. But if you take aortic valve disease and coronary disease and mitral valve disease, that makes up 90% of what's done in adult cardiac surgery. So these two papers pretty much cover everything. And again, Ralph found that there's no additional procedural mortality or morbidity with this procedure. So the question is, if you don't have, if you don't increase the risk, there have been other studies that have shown this now, but if you don't increase the risk, why not add it to one of these three main procedures? Well, some people felt that there was not really any demonstrative advantage of doing so, and there are some papers out that might suggest that. And as I hasten to add, these are not prospective, randomized, double-blinded trials. But Ito published in 2006 in the European Journal the difference in the long-term stroke rate in patients who were treated and untreated, and showed a significant difference, statistically significant difference. Fukunaga published a paper from Japan in 2008 showing the difference in treated and untreated patients in terms of long-term thromboembolic and valve-related events. One of the things I used to get asked a lot is, why would you ever do a MACE procedure on somebody who's having a mechanical mitral valve? Because they're going to be anticoagulated anyhow. Well, the answer I always gave in this study, and several others now have shown the same thing, is that these mechanical valves are almost always bileaflet valves. And those bileaflet valves are all designed for their hinging mechanisms to be washed on every single cycle. And if you have a valve and atrial fibrillation that's flopping around, so sometimes one of the leaflets doesn't open, that valve can't possibly be washed as efficiently as it can in sinus rhythm. This study and several other studies have now shown that you have actually an increase in the valve-related thromboembolic problems in patients who are in atrial fibrillation if it's a mechanical valve. This same study showed that if you look at all cardiac complications in patients who are treated and who aren't treated, there's a substantial difference, a statistically significant difference. And finally, this is one of about 6 non-randomized studies that all show the same thing, and that is that if you treat the atrial fibrillation at the time of surgery, it's as if the patient never had atrial fibrillation pre-op in terms of long-term survival, that is 5-year survival. So there's plenty of reason why we should be doing this, I think, in these concomitant patients. But I think the only way that we're going to get from 20% to, let's just pick 80%, is one single thing, and that's surgical education. Because the questionnaire at the AATS showed that the concerns that surgeons have as a result of of this questionnaire simply aren't valid concerns. And I think most surgeons aren't aware that there are numerous publications indicating that patients actually do better in a whole variety of ways, including quality of life, which is a major one, if you do take care of the AFs at the time of the coronary, aortic, or mitral valve surgery. Well, where are we going in standalone? And as I said, I think these last few papers have given us a very clear idea of what our options are. If we look at standalone AFib and go back to our slide of 2% and 98.5% and 3%, I guess the question to ask is, what are the real options in these patients that are all treated with drugs? Surgery has not been an option because the minimally invasive, cardiologists just don't want to do surgery of any kind, even minimally invasive surgery. But minimally invasive has been a term, I think, up until just recently that's been stretched a bit. But I'll mention that. The catheter ablators have really one of two choices in patients if they want to get into this, trying to treat this group of patients. I think it's clear to everybody now that catheter ablation, as it exists today, is certainly not the answer. 20% at 5 years is not an okay treatment for anything. And so I think that even the cardiologists have come to grips with that. And I think that's one of the reasons that the concept of the hybrid procedures is opening up. They have one of two choices. They can either do an ablation of the His bundle and put a pacemaker in, and now do an internal closure of the left atrial appendage if they want, because if they ablate and pace, they can take patients off their antiarrhythmic medications. But they've always had to keep them on anticoagulation because they've not removed the potential for thromboembolism. If they ablate, pace, and occlude, and the percutaneous studies do show that you can take the patients off of anticoagulation, then I think that you'll see a lot of patients done that way, a lot. The only other option, I think, or the only viable option at this point, is to combine what the catheter boys can do and what surgeons can do into hybrid procedures. And I think that's why the hybrid procedures are gaining so much emphasis now. That plus the fact that the results that have been reported are quite good, as you saw some today. The 2012 guidelines define hybrid procedures as a joint AF ablation procedure performed by EP and surgeons, either as part of a single joint procedure or performed as two pre-planned separate ablation procedures separated by no more than 6 months. Well, that means one option is to do the joint procedure, as Mark and his group do in Maastricht and Brussels. Another option is to do an initial catheter ablation followed by surgery at a later date, but basically all the surgery we do is that option. So that's not really something I think could fairly be classified as a hybrid procedure. But interestingly, the initial surgery followed by catheter ablation, as Muniretta and Bisleri have done in Brescia, has gained a lot of interest. My own personal well, I'll get into that. I'll say it now. My own personal preference is to do the initial surgery first. And the reason for that is that the only theoretical problem that I've had with the joint procedure is you do it, Mark, and as a few others do. Andy Kaiser and Mounsey do that at UNC with the convergent procedure. The theoretical problem I've had with that is that I do not have a lot of faith in intraoperative testing. And the reason is that no matter what device you use, I think that if whatever you test in the operating room tells you what the status is in the operating room at that time. You find the immediate results of your lesions. But we all know that those lesions change with time, whether they're cryo lesions or RF lesions, they change with time. And my concern has been that there would be a high recurrence rate later. That's why I was so interested in your 5-year data, because your results are excellent. I think you reported 83% at 1 year, and now 78% or so at 5 years. So that may be a misplaced concern, I don't know. One of the other problems with the joint procedure, at least in the States, is that it takes so long to do it that a lot of places in the States won't reimburse you for it. I mean, the hospital won't let you do it. It takes too long. So we work with a 90-day period of time and so on in terms of reimbursement, getting reimbursed for it appropriately. These are, I think, the three best and major studies in the medical literature on the long-term efficacy of catheter ablation. And the reason I think they're the best is they all have 5-year data, and they're all done by people who are as respected as any 3 people in the world of catheter ablation. The first was done by Hugh Calkins, whose name is, he's the first author on practically every guidelines that comes out on this side, on our side of the pond. That was done at Johns Hopkins, of course. The second one was reported by Hassegaer, who is the father of all catheter ablation for atrial fibrillation. And the third is by Karl-Heinz Cook, who's been mentioned a couple of times today. I've known Karl-Heinz Cook for about 30 years now, and he's an absolutely superb electrophysiologist, as these other two guys are, and he's superb with a catheter. So the results I'm going to show you are their results. They aren't my results, they're their results. And we've seen some of these before, but I guess I don't have the full slide. But if you look at the individual studies, this first study by Calkins was published in 2006, which is a little old. They had 200 patients they followed for 22 months. Single catheter, multiple catheter. And they looked at them at 2 years, 26 months. With single catheter ablation at 26 months, the success rate was 28%. With multiple catheter ablation, the results were about 60% or so. What's sometimes overlooked is that 63% of those patients, no, I'm sorry, I beg your pardon, 48% of those patients, basically half, had paroxysmal atrial fib, which they're supposed to be really good at. And so at 2 years, single catheter ablation, 28%. This paper that came from Michel's group, Hassegaer's group, was published in 2011, January, 3 years ago now, in JACC. And it had 100 patients that were followed for 5 years, and they were looked at 1 year, 2 years, and 5 years. And for single catheter ablation, remember Calkins was 29% at 2 years, or 28% at 2 years. Hassegaer was 29% at 5 years. And I told Michel once, I said, well, you guys are getting better, you've gone up from 28 to 29. But the multiple catheter ablation, the success rate was 65% at 5 years. And again, 63% of those patients had paroxysmal atrial fib. So it's not, they're not failing because they're not trying, they're not doing patients that they should be getting. They're doing some persistent, long-standing persistent. But in those two studies, half, and in here, 2/3 of the patients had paroxysmal atrial fib. In this study, Karl-Heinz Cook was published in 2012, and it's the so-called Hamburg sequential ablation study. I don't remember the number of patients, but he had quite a number of patients. Some of you may remember. But he had, all of his patients had long-standing persistent AF, the hardest group. And at 5 years, his success rate for a single ablation was 20%, for a double ablation it was 45%. So if you look at the two studies, Hassegaer's study, 29 and 63, single, multiple, and Cook's study, 20 and 45, single and multiple. At 5 years, using their data, that's why I say that it's a single catheter ablation gives you about a 25% success rate at 5 years in the best of hands, and multiple catheter ablations give you about a 50% success at 5 years. And that's the reason that it seems to me people are opening up some to hybrids. Third-party payers, at least in our country, and I was stunned at that presentation of the NICE study this morning. I've heard rumors for 6 months that there was going to be some cutback on the reimbursement for non-paroxysmal atrial fib. I guess that's changed. But that's certainly being looked at in the United States. The payers aren't going to pay for this forever, but not with these results. But nevertheless, I think all those factors play into the idea that we need to do something else. Surgery is too invasive. Catheter ablation is not good enough. These are the actual data from the single ablation. This is Calkins study, 2 years. Hassegaer's study at 1, 2, and 5 years. Multiple catheter ablations. This is Calkins at 2 years, Hassegaer at 1, 2, and 5 years, and Cook at 5 years. So if you look just at the multiple catheter ablations, one of the things I hear a lot when I go around talking is especially from young electrophysiology, interventional electrophysiologists as well. I don't know why you'd want to do surgery, because I can do catheter ablation on anybody, and I can get an 85% to 90% success rate in a year. And it's actually true. I mean, they did too. You know, if you look at a year, that's about where you sit with multiple catheter ablations at the end of 1 year. The problem is, at the end of 5 years, you're down here. And that's not okay. I don't think anybody should even be looking at 1 year results in surgery or catheter ablation. So if, let's say, we did a two-step catheter ablation, if we considered a two-step catheter ablation, catheter followed by catheter is a hybrid procedure. Let's say we're going to do a prospective randomized trial, catheter versus surgery. I would suggest that it be done surgery catheter as one arm, catheter as the other arm, okay? And then cut it off there and see what happens. Well, if you did catheter first, you're going to get about 40%. You go out a few months and see who recurs, do a second catheter ablation, which is quite routine. We know that after a year, our results are going to be right there. That's where our results are going to be at the end of 1 year. But we also know from these studies that have been published that if you follow those patients for 5 years, you're going to be there. So if you did a quote-unquote hybrid with catheter first, catheter second, and follow them 5 years, we know what those results are. I mean, it's very clear what those results are. It's around 50 to 55% if you had a catheter ablation as the initial procedure. What if you do a surgical procedure as the initial procedure? Well, if you did a staged surgical procedure, usually around 75–80% of the cases are free of atrial fib after you get through with the surgery. And then you do a catheter ablation, a planned catheter ablation on the end of that. By 1 year, you'll be well over 90% success. If you follow that, Bisleri's group, although there's always been some argument about how you report your results, but the fact is it's made above 90%. That's at 3 years. And then you would expect that at 5 years, it's going to stay around 90%. That's the reason I think that it makes sense to do the surgery first. Well, why hasn't this been done before? Well, the reason it hasn't been done before is because these are the kinds of quote-unquote minimally invasive procedures that we were offering as a first-line therapy. This is what's been developed over the last 10 years or so. It included general anesthesia, endotracheal intubation, deflation of both lungs, bilateral pericardiotomies, the Wolf procedure, post-op chest tubes, and cardiopulmonary bypass, and that's just too much. So that's, the question you have to ask is minimally invasive compared to what? Well, it's minimally invasive compared to a median sternotomy, but it's not minimally invasive compared to a blood vessel puncture in the groin. And I think that's the reason that this has not been seriously considered as an option in the past, because the surgery is just too much as an initial step. They're not going to let you do this. But with this kind of surgery now, and I got this from Claudia Munaretta, being able to do what you guys can do now, which we never even approached years ago. I think you all grew up playing too many games, or those video games. But whatever, this is a patient that had one of the procedures that Gianluigi Bisleri just described. And that's quite a bit different. Cardiologists look at that, they don't shy away so much. And if you can put lesions in with stab wounds like this, and like Mark does and some others, I think it's obviously a lot more palatable to consider surgery as the first procedure if you're a cardiologist. And if you don't work with the cardiologist, we've learned over the last 15 years you aren't going to get any patients to amount to anything. That's just the fact. So with these type of Band-Aid lesions here, when you get through, I think it's reasonable now, and I think a lot of cardiologists are buying into this now, that you can do this surgery first. Now, one of the things about the Mays procedure, when we developed that procedure years ago, we knew about half a dozen reentrant circuits had actually been mapped in the atrium. We'd mapped some. March Alessi had done it in the lab and so on. But we didn't know where they all were, but you could look at the atrium and see what size these things were and figure out where they could be. So it was based on putting lesions so that no matter where those things are, they can't form. They simply can't form. Well, what we've learned since then, mainly from the cardiologists, we do know where those reentrant circuits occur now. And this argument that's going on about the size of these rotors is going to go away because that's not sound physiology. But we do know that people have described a reentrant circuit. This circuit right here is described by both this one and this one by Sonny Jackman. Several people have described circuits going around the pulmonary veins and so on. There's not an infinite number of places these reentrant circuits can be. Well, I'm just talking about the left atrium now. And I'm talking just about non-paroxysmal atrial fibrillation. So when you do the lesions, if you do a maze 4 or a maze 3, whichever you isolate the box, however you want to isolate it, you're in fact interrupting a good number of those reentrant circuits, and that's why it does work in some people, because you're primarily dependent on whatever reason in that patient, primarily dependent on. But there are other areas out there. There are a couple I haven't shown you just for simplicity's sake. But the reason you go out to the left atrial appendage and take it off is not only to get rid of the risk of thromboembolism, in my opinion, but also because it improves your electrophysiologic results. And a lot of people have shown that now. So it's not something for discussion. Well, everybody who does a thoracoscopic procedure, I'm sorry that Aladdin had to leave earlier because I watched him do one once, at least on video, can do this. Everybody can isolate the pulmonary veins. And by one way, or hook or crook, this is a long line on this drawing, but everybody knows it's only about that long. Now there's a little ridge there that really bugs the cardiologist, but it's only about that far. And so that lesion is not big, but you get a fair amount of reentry right at that point where it goes across the gap between the internal orifice, the left atrial appendage, and the left superior pulmonary vein. So you make this lesion, and then you take off the left atrial appendage, and you don't do anything else. Now, I'm sure that's going to surprise somebody because I've harped for 20 years now or more that you always need to put the mitral line in everybody. Well, there's one problem. You can't do that with a scope because of what Manuel just said. You can't do it. Nobody can do that on a consistent basis with any kind of energy source from the outside of the heart. You just can't do it. So I know Mark does a combination of epicardial ablation and endocardial ablation because you have the guy in there with you. But let's assume he's not going to be there with you if we do it this way. It would be a bad idea to even try to put that thing on surgically if you don't have an electrophysiologist in the room with you. Because if you make an incomplete line, then that line is arrhythmogenic, and you'll make things worse. So we've gotten rid of most of the reentrant circuits. Notice I haven't said anything about perimitral flutter yet. I'll get to that. At this point, you're on the epicardium through a thoracoscope. At this point, I would strongly suggest you do what I used to do for Bruce Lindsay, and that is put some radiopaque vascular clips below the left inferior pulmonary vein and on the coronary sinus. Why? Because you're going to have about a 15 or 20% incidence of perimitral atrial flutter in these patients. Now, the reason I always insisted on putting that line in is because I didn't know which 20% that was going to be. And I was there for an absolute, and all of you have done the MACE procedure, you're there for an absolute definitive procedure. You don't get a second chance, and you don't want some cardiologist coming back and fixing your problems. So you have to do all 100 out of 100 patients, you put the line in and the coronary sinus lesion on and so on, just to keep the 20% who need it from developing perimitral flutter. Well, now we've got a different philosophy, you see, because we're not doing a definitive surgical procedure here as the first step. We're doing a procedure that is a hybrid procedure. We're trying to put down some lines to make it really easy for the cardiologist to come back later and complete his procedure as needed. So you put these clips in here, but you don't do anything else. Thoracoscopic procedure, pulmonary vein isolation, left atrial appendage, vascular clips, okay? On the right side, this is an excellent paper that if you haven't read it, you should. It's in Heart Rhythm in 2009 by Santucci and his group. And he showed potential right atrial, well, he showed the right atrial reentrance circuits that actually mapped, because people keep saying that the right atrial lesions aren't necessary. Well, they are, because you can have a lot of reentry in the right atrium, macro reentry. These are the three types of atrial flutter waves you can get, and they can be peritricuspid, where they go around the tricuspid annulus. They can be a flutter wave. This is a classic flutter wave using the cavo tricuspid isthmus and going anterior to the orifice of the SVC. And this is, I thought, more classic, more common, but it turns out this is about 50-50, where the flutter wave is the same wave as this wave, except it goes behind the SVC instead of in front of it, okay? So let's see what that looks like in real netter life. This is the one that goes from the cavo, uses the cavo tricuspid isthmus, and it goes behind the orifice of the SVC. So there's where your reentrant circuit is. This one is the same circuit, utilizes the cavo tricuspid isthmus, but it goes anterior to the SVC. And this one is the one that goes around the mitral annulus, the tricuspid annulus, sorry. It uses the cavo tricuspid isthmus. Where else can you have reentry? Where else has reentry ever been documented in the right atrium? Well, it's been documented to occur around the SVC plenty of times. I've never seen one around the IVC. I had dinner with Michel Hassaguer in Bordeaux about 3 months ago with him and Hocini. I said, have you ever seen that? He said, oh yeah, I see it all the time. Not commonly, but I see it, yes. I said, okay, have you ever seen one? Well, I won't get into that, but I asked him about another one, which is just going to make things complex, so I won't mention it. So he said, yeah, I see that all the time. So it's obvious that you can get most of these. You can get most of these by just doing a flutter line on the right side. But there's another one you can't get, and that's this one up here. And that one, if you just put an SVC to IVC line in at the time of your initial surgery, then it gets rid of the possibility of that one around the SVC, the posterior type of atrial flutter, and the one around the IVC if it's going to occur. So when you come back for your catheter ablation, the only thing that can happen on the right side is this around the peritricuspid and this anterior type of atrial flutter. And fortunately, they both use the cavo tricuspid isthmus. Now, for completion's sake, because you're going to hear me say this one day, you can't have it around the base of the right atrial appendage. And so I would actually, if I were doing it, I'd put another lesion in here. And I asked him if he'd ever seen that. Again, he said, yeah. Anyhow, for the initial surgical procedure, pulmonary vein isolation, left atrial appendage, perivascular, radiopaque vascular clips, and an SVC to IVC line. You see how I moved this thing lateral, Mark? I had drawn this thing incorrectly for years, as Mark pointed out to me a few months ago. But you go from the SVC to the IVC for the reasons I just mentioned. That is a very doable procedure as the initial surgical step. It's very doable. All right? So let's say we do that, and we come back. This is not a complete maze procedure. We come back after I think a 90-day waiting period is optimal. That's what we've always used. We use that with a cut and sew maze, and keep in mind, we didn't have to wait for the lesions to mature. You wait 90 days for the atrium to settle down and get over your surgery. That's what you wait the 90 days for. So the only thing that you can have on the left side is perimitral flutter. And it can go either by the myocardium and the left atrial isthmus here, or it can go by way of the coronary sinus. Don't leave the coronary sinus lesion out. Cardiologist can see, all he has to do is put a string of lines, a string of lesions between those two vascular clips. They love that. That distance is actually a shorter distance than the flutter wave lesion on the right side. So there's no reason they can't do this. But when they don't know exactly where that line is supposed to go, or exactly where they put the lesion the last time, they don't have any radiopaque markers to go by, then it gets a little dicey as to whether they can do it. They then pass the catheter in the coronary sinus, because this can still occur, pass it in the coronary sinus and buzz right where that clip is, and I promise you, you won't have any more perimitral flutter. That's only going to be necessary in about 15% of patients. The other 85% of patients don't need that lesion. Okay? If they need it even after your waiting period, it's easy to do. That is a maze procedure on the left side. That's the lesions, the left-sided maze procedure. On the right, the only thing can happen is flutter because of these two things. And so what do? Well, you put the flutter line in. They do that all the time. And you've gotten rid of that. I would add a lesion from here to the left to right atrial appendage, but we figure if we can get surgeons to do this, we'll just stop at that, because the thing that's least common, the least common reentrance circuit in the right atrium is around the base of the right atrial appendage. It's almost theoretical. So I think this will be plenty, because we know that's where the reentry occurred. It's why you asked me, it seems like yesterday, but I guess it was this morning, when you asked if I could leave one lesion out, which one I'd leave out, and that's the one I'd leave out. Because reentry around the base of the right atrial appendage is exceedingly rare. Well, so you've done this as the initial surgical procedure, and you've completed that if needed, completed that. And from a functional standpoint, this actually is a complete maze procedure. And there's no reason you shouldn't get exactly the same results. So what would be the impact on cardiac surgery in the States? And I said here you can multiply this by 1.5 to 1.8. There are about 60,000 catheter ablations, 20,000 surgical ablations a year. We do about 400,000 total cardiac surgical procedures a year. There are about 3 million people who live there. If you had a 13%, if you did these procedures on 13% of that 3 million people with atrial fibrillation, you'd double the cardiac surgery volume in the United States. And you do the same thing here. So I think this is important. It's an important disease, and I think we have ways that we can absolutely cure it now. Particularly I think if we work with a cardiologist, I think it's important to stage it, but I may be wrong about that. I mean, your results are very good, and we'll see what happens. But I think I'll stop there. Again, I appreciate the opportunity to talk. I did have one slide. So the problem with inadequate concomitant AF surgery, I think, can be corrected by more surgical education. And the problem of having no effective treatment for standalone non-PAF is to get an effective hybrid procedure. At least I think that's where we stand right now. Thank you.